You're listening to All the Pieces, a podcast created to keep you informed. Now here's your host, Chief Quality Officer, Dr. Curran Mohan.
Hello and welcome to another episode of All the Pieces. I'm your host, Dr. Mohan, hospitalist and Chief Quality Officer. Today, we'll talk about something that is very serious, which is hospital-acquired infections. Every patient deserves a infection-free experience, but infections do exist. And for those, I have two experts with me today, Angie and Danielle. And before we get started talking about what those infections are, I would like to introduce themselves.
I'm Danielle Wilson, and I'm the Infection Prevention Manager here in St. Joseph at Mosaic. And I have been with Mosaic for, it'll be 22 years here.
Wow, congratulations.
Yeah, here this summer. And most of that time I've been with infection prevention, but I've also had one of our ICU nurses and then education. So
a little bit of all.
Things. Yeah.
Excellent. Angie?
I am Angie Conard. I'm our vascular access coordinator for the hospital. I've been with the organization for about almost 15 years. Things that I do is I do round on all of our central lines, keep eyes on those. I'm doing that at least twice a week just to keep eyes on them, make sure we're doing best practices. If there's any follow-ups, I do just-in-time education with our caregivers at that time. And then I also will go and do difficult sticks for our nurses as well. So I'll do IV access for them. I'll place midlines as well. So some different things I do.
So a little bit of everything, but specifically to central lines.
Yes.
Excellent. So let's dive in. I alluded to infections in the hospital, and that can range from anywhere from C. diff. For our listeners, C. diff is an infection that can affect your gut. But more specifically, we're going to be talking about CAUTIs and CLABSIs. Can you describe what a CAUTI is? It's an acronym, which is something in healthcare we're full of, but Danielle?
So a CAUTI would be an infection that is related to a indwelling urinary catheter. So a lot of people will call that a Foley catheter. And so it's that device that's placed to help you drain your bladder. And anytime you place a device in a patient, you have a risk for infections to get into the patient.
Absolutely. And since central line is your jam, Angie, what is a CLABSI?
A CLABSI is a central line associated bloodstream infection. So it's truly those catheters that are, a PICC line, a CVC, even hemodialysis lines qualify as a central line. And it's that infection that is an attributing cause to their infection.
Gotcha. So it is not a line that most people see in the TV shows where it's in your.
Correct.
It might be in your arm or it might be in your neck, but it's a little more deeper.
Absolutely. Yeah.
Foreign object really in your body that's to give medications or sometimes even to draw blood. And for hemodialysis is to do that little hemodialysis through that
Correct. Yep.
access. So obviously these things are foreign to the native body, right? These things are not something they were born with. There's something that gets placed in the hospital.
Right.
Therefore, anything foreign and that is not natural has a high propensity for infection, correct?
Yes. We talk about the chain of infection. So there's lots of different things that either the environment, the patient, things that we do to the patient. When you look at these lines, I was at a conference one time and they described it as plastic. Anytime you put plastic in the patient, you're potentially having that risk that it's a brand new way in which things can get in, or you can take things out. Like with the dialysis patient, you can help them, and we want them in the right patients, and we want to get them out whenever they're no longer needed.
I understand. So why would anybody get a central line, or why would somebody get a catheter placed in the hospital setting?
So you want to talk about the indications?
So indications for a central line are, of course, if we have hemodynamically monitoring a patient, we would want them to have a central line. If they have antibiotics over about 4 weeks, we'd want to do a central line for long-term antibiotic therapy. Also, if they have multiple incompatible medications in those vesicant or those medications that are very hard on the veins, we would rather them have a central line versus breaking through the peripheral vasculature of the patient.
Gotcha. And sometimes even the elderly patient, which is something we see a lot of,
Correct.
they may not have the best veins in general, or they're in a longer course of treatment, and the doctor or somebody would recommend, hey, they would need a benefit from a central line or a PICC line.
Correct.
What is a PICC line?
A PICC line is a peripherally inserted central catheter, so it gets inserted in the upper portion of the arm, in one of the 3 big vessels up there, and then it actually travels all the way to the heart, and it terminates right before it gets into the heart. So
Wow.
It's called that superior vena cava of the heart is where it terminates at.
So it's a big big plastic snake that essentially goes from your arm to your heart
Correct.
for you to get your medications.
Yes.
It sounds a lot more intense when you speak out loud of it, but for common medical practice, it is our...
It's kind of our go-to.
It's kind of our go-to, exactly right. And same thing with the Foley, I'm assuming?
Yeah. And so with the Foley catheter, the indications for a Foley catheter would be they had surgery and they need to, maybe it was on the bladder itself, so they need to protect it and keep that open. They have immobility. They had a major trauma. They had a big car wreck and they have to have a way to get that urine out. The times we don't want to put it in is, the patient maybe had it last time, so it worked well. Let's do it again this time. That isn't an indication. It's truly they can't get that urine out in a safe way. And so we want that, or we maybe with those critically ill patients, we need to be able to monitor, are their kidneys functioning? And so we need to see how much urine comes out every hour. And so those are the kind of patients we want to keep the line in. And then the other patients, we want to switch them to a different device.
That makes sense. So the sicker you are or the more immobile you are, the possibility of more foreign objects being in your body goes up, which is kind of a double-edged sword, isn't it?
It is.
The older you are, the sicker you are, and you're putting in more objects in your body that is not something you were born with, so your chances of infection technically goes up as well.
Right.
Mm-hmm.
And on top of that, you're in an environment which is surrounded by other people's infections. So it's like a triple-edged sword, if that's a way of putting at it. So what is something, as a layperson, if I'm a patient coming in, what do I need to be aware of when I'm coming into an environment where they might put a Foley catheter in or a central line in me, and I'm fully, I can make my own decisions? What is something I should need to know about the risks and dangers of it?
Well, the first thing I would want them to do is ask, why do I need it? And so if I truly need it, let's do it. And then how soon do you think we can get that out? How long will I need it? And then those are the two things I would want to know as the family member or as the patient myself. And then how are you going to take care of it for me, or what can I do to help take care of it so that we keep everybody safe? Do we need to bathe more often? Do they need to do cleaning, like a Foley catheter? They need to do cleaning of the perineum of the patient and keep that whole area free of burden. For the central line, same thing. We need that patient to get a bath today because your body has natural bugs that live on your body that help keep you well. But if those get out of control, they can be introduced into your line somewhere, and then you end up with a bug that's normal in your skin that doesn't hurt you at all. But if it gets in your bloodstream, it might be a big problem for you.
Especially when it's that close to the heart.
Yes.
Right.
And so something as simple as washing your hands before anybody touches any of your lines, or if you touch it, getting that bath. Those are easy things that can be done. And then when you no longer need it, get it out or switch to a different device.
Gotcha. So it sounds to me, from what you're describing, that prevention is better than cure. But before that, first even assess if the patient needs it.
If they need it.
If they don't need it, don't put it in.
Right.
And if they do need it, definitely take care of it. Now, this is a more technical question maybe, but Angie might be able to help you with that. When is the most likelihood that an infection is going to occur, which is at the point of when the device is being put in, or is it the maintenance part of things?
So what we're seeing here is the maintenance. It's the care and maintenance that we're seeing could be potentially affecting our lines. Some things that we're doing just to kind of mitigate that is, like I said, I go out and I look at these central lines, lay eyes on them, make sure we're doing best practices. We follow a CLABSI maintenance bundle.
Sounds fancy.
Compliance. Yes. And we really want our caregivers to adhere to that. Some things that are inside that bundle are ensuring that the dressings are clean, dry, and intact. Even if they're noticing something's going on with their line, it's peeling a lot, I don't like that, let your nurse know so that we can get that dressing changed.
And we're assuming that the patient can talk and give feedback, and it's not like intubated in the ICU.
Correct. Yeah. And our nurses should be rounding on their lines every 2 hours, and I always tell them, lay hands on it, palpate that, touch it is what I mean by palpate, so that you can feel, hey, am I feeling any swelling? Is there any redness, any signs of infection that we need to be aware of, and that we're reporting those to our providers taking care of the patient.
Gotcha. So as you alluded to earlier, was the patient being able to talk and relay some information. Is pain a factor?
It is. Pain is your first indication that a line is going bad. So truly, if your patients are saying my IV hurts, my midline hurts, I'm experiencing this pain, please listen to the patient, advocate to get the line switched out, get them a new line, make sure we're checking those lines that they're functioning to the full capacity, they've got good blood return, they're flushing well. So those are items that we would want to keep an eye on, especially if that patient's complaining of pain.
So that's a first indicator that, hey, something might not be going right. And as a nurse or even as a tech, somebody who's interacting with the patient can relay that message up.
Absolutely.
I know this is infections happen, right? This is part of our healthcare diaspora. It's not us, it's everywhere. What is our goal for infections in general, for CAUTIs or CLABSIs, Danielle?
Well, specifically for CLABSIs, our goal is typically 0. We do not want to see that. We do benchmark against other national information. We benchmark against other like-size hospitals.
So other hospitals the same size as Mosaic, St. Joseph, or Maryville?
And we participate in actually all of our hospitals, Mosaic, Maryville. We participate in government reporting. And so then with that, we're able to see, okay, we had one infection on a certain time frame, and we can look and compare, another regional hospital like St. Joseph, how many did they have during the same time frame? And we then can go, okay, what strategies can we do because we're at the benchmark, or we're above it, we're below it. How do we get, well, the below it we want to stay at. If we're above the benchmark, what can we do? And one of the biggest things we found over time is that we need to do is decrease the number of lines we use, whether that be central lines or Foley catheters. And so that's how one of the things that Angie and I have been strategizing is get the right line in the right patient, but get it out when we don't need it. And if we decrease, if you just don't have the line, you don't get an infection from it. And so decreasing that utilization from the benchmarking data has been one of the best things that we have done. And we have seen some reduction over the past, because we've been working pretty hard at this for about 6 months for reducing the total number of lines we use. And so that's been our biggest strategy for reducing the number of lines, because infections do happen. There's always going to be that someone who came in, and no matter what we did, their infection, they were just so at risk that one little thing upset the apple cart.
That's a very good way of putting it. So it is a sheer volume thing. So the amount of lines there are for times that many amount of days, the chance of you going or having a infection goes up.
That's where our data shows. If you keep it longer than 4 to 10 days on a Foley catheter, your risk of having an infection increases dramatically.
And that makes sense because it's like kind of like driving 125 miles an hour. At a certain amount of time, the longer you do it, the chance of you getting pulled over goes higher up. In this case, infection being the police officer, I guess.
The national data on hospital-acquired infections, 1 in 25 hospitalized patients will get an infection. So if you think about Mosaic Life Care, we have, on a given day, we usually have over 200 census.
Right.
And if you apply that to any hospital, that's a pretty significant number of patients who could be affected.
And how does that impact the actual patient care or even Mosaic's sort of overall, picture if the patient gets a CAUTI or a CLABSI?
So the direct impact to the patient could be, downstream effect of they have to stay in the hospital longer because they have to have an antibiotic to treat that infection.
A stronger antibiotic.
Yeah, additional ones added in. And then we have to we have to put a line in.
Right.
Then that patient, it could be 1 antibiotic or 10 antibiotic doses. They can end up getting C. difficile, and that could be another hospital-acquired infection.
This is like probably the worst patient experience ever. They came in for a simple hip fracture, right?
Yep.
They got a Foley catheter put in, wasn't removed in time. It turned into a full-blown septic picture.
Yep.
Now they got a central line put in because of antibiotics. And then that turns into another infection. Then that turns into a C. diff. Obviously, we're being very reductive here, presuming that all these horrible things are happening. But can it happen? Absolutely. So therefore, our goal is to always have 0 infections for any of these lines. Is that an unattainable goal? Is it a lofty goal?
With central lines, I think it's a goal that we definitely will strive for every day. To have 0 infections, those organizations, we want to borrow some of their best tricks. Because 0 is a difficult place to be because of those things that I mentioned earlier about.
Right.
Sometimes that patient comes in and they're so sick and so susceptible that zero is always our goal, but might not always be there.
We've done some collaboration with Mayo as well on what are they doing, what's best practices. Recently had a call with them on, what are some things they're doing to improve practice. And they definitely are great at, spitfiring some ideas for us to try and do to make improvements at our hospital. And our goal is to, ultimately align with them with that partnership we have.
Excellent. And that's a very great resource to leverage to make sure our patients are getting the right care at the right time. So you said you've been working on this for the last 6 months.
We've been working on CAUTI and CLABSI reduction for many years, but this newest initiative's been going on for about the past 6 months. We've, over time, worked on different parts of it. Several years ago, for urinary catheter, for CAUTI reduction, we worked on getting external devices. So instead of putting inside the patient a Foley catheter, using an external female catheter, an external male catheter. There's even commercials about the external female catheter.
Right, I've seen commercials for those.
Yeah, and so those are, that external catheter was invented by an individual who had their loved one was at home and needed a device to maintain their urine. And so, it's just that necessity is the father of invention.
Right.
And so we want those devices used when appropriate. We had great results with patient satisfaction with that. And so we've implemented it, and we've seen really good impact on avoiding some of those placements of the indwellings. For the midline program for the central line avoidance, if we don't need that line because they're going to be on antibiotics for 4 to 6 weeks, they only are going to be here for
like another 2 weeks, or they just need outpatient antibiotics for another 2 weeks. A midline's perfectly acceptable for them to go home with and do their outpatient antibiotics with that midline instead of having a central line placed.
So what is a midline?
So a midline, how I describe it to patients when I'm placing them, is it's the in-between of a peripheral IV, so a short IV catheter, and a PICC line, a central line. It goes in the patient's upper arm. It's placed by one of our trained nurses with ultrasound guidance as assistants to ensure that they get that catheter right in the vein and it's perfectly placed. And it should dwell for that. They can dwell up to 29 days.
Wow, that's a pretty significant amount of time.
And so really, we do not need to have that central line for long-term antibiotic therapy anymore. We can place the midline. But I do want to emphasize that each line has their specific purpose. So if your patient does need a central line, we're not saying, no, don't put it in. But if they do have to have one, that we're doing good care and maintenance, we're meeting those bundle compliance elements, and that if the patients are experiencing anything, they're speaking up and letting us know that we can fix that for them.
Excellent. So, Danielle mentioned strategies to reducing, catheter-associated urinary tract infections. What strategies are you using, Angie, in your practice daily?
So some things that we're utilizing in our practice is when I go in round, if I'm noticing that we're not using Kuros caps, and a Kuros cap it's a green cap that you guys will see on your lines. It has alcohol impregnated sponge inside of it, and it keeps that hub of the catheter clean from any bugs outside in the outside area. And so really, if any of that's missing from the patient's actual catheter or from the IV tubing, I'm meeting with the caregivers, I'm having conversations with them, doing just in time, letting them know the why. If you ever talk with a nurse, we always want to know the why. Why are you telling me I have to do this now? So the Kuros caps are a big thing. Our 4 East Oncology unit had implemented the Kuros caps on their unit, and it actually decreased their CLABSIs to 0. And
Amazing.
They did excellent with it. Kelsey Phillips, their director, actually had a whole presentation on why she did it and things. So it was awesome. That's what we want to see. And I use that unit for an example because not only do they use the correct products, but they hold each other accountable as well. It can be the nurse, it can be the PCA. If they see someone walk in and not do hand hygiene, they'll call each other out and they'll say, hey, make sure you do your hand hygiene, or do your hand hygiene when you switch your gloves. And so they really hold each other accountable. And that's the first expectation we have to make sure that these projects all align right. That
is a great information, and kudos to Kelsey and her team on 4 East. And what struck out to me when you were talking was that every part of the line felt responsible to be an advocate for the patient.
Correct.
So that's a twofold benefit for where I'm looking at it, which is they all feel psychologically safe to voice that, hey, this patient needs this, or hey, you did not wash your hands when you were touching the patient. On top of that, good practices are hardwired. So That is an excellent, the way I'm looking at it is an excellent approach to good, safe patient care, which is a team effort.
Yes.
And it's all clean hands on deck,
Absolutely.
right?
And it's a compromised population.
Absolutely.
And their strives have been very good.
So I thank you both for sharing some amazing information with us. To our caregivers who are listening, know that you have an equal part in making sure the patients have a safe and infection-free experience here at the hospital. And for our non-caregivers who are listening, just know that if you're in the hospital, lines may be a part of your experience, but you should be an advocate for taking them out if you don't need them. So with that, I want to thank you again, Danielle and Angie. You guys are doing tremendous work, and I look forward to seeing some more improvements. And with that, I will see you next time. I'm your host, Dr. Mohan. Take care. Brush your hair.